Hello, wherever you are. Welcome to the IGCS 360 education platform. I'm here with my distinguished guest, Dr. Rob Coleman, who's going to introduce himself here in a moment. And today we're going to talk about mismatch repair proficient recurrent endometrial cancer and some opportunities in this space and clinical trials and development. I'm Flora Backus. I am the co-chair of the Advances and Updates for IGCS 360, and I do this together with Dr. Wendell Nauman, and I'll let Dr. Coleman introduce himself.
Thanks so much, Flora. It's great to be with you. So Rob Coleman, oncologist, now residing in Georgetown, Texas, because we have international everything here in Texas, which is just north of Austin. I work at US Oncology, and I am the immediate past president of IGCS. So it's great to be with you. I also serve as the PI for the US on the XPOR-DC trial. So I'm really happy to have this opportunity to speak with you today. Thanks for the invitation.
And it's been quite a year for endometrial cancer. I can't believe that it was just a year ago that the data were presented for and recurrent endometrial cancer with immunotherapy added to chemotherapy. And it's really changed our landscape. And we've talked about in these sessions, we've had a session on the mismatch repair deficient population and how the magnitude of benefits that just blows all our minds, but we've really adopted that as our new strategy. But for this pMMR mismatch repair proficient population, we see a benefit there, but not as big. And I was wondering if you would be able to talk about some of the results that we've seen over the last year also developing in this pMMR space and potential other maintenance treatment options rather than the immunotherapy.
Yeah, boy, hasn't it? It's really, it is kind of amazing. I think for those of us who have been in this business for a long time, have been always, we almost have to pinch ourselves to see that there's so much development in a disease that really most people just kind of said, well, you got frontline chemo, and that's really about it. Patients are too sick to get anything else. And, now we've come to this point where now the molecular annotation is becoming so important, just as you mentioned. Obviously, one of the biggest critical factors is this MSI MMR status, because that's allowed us to differentiate really two cohorts. And I love the way you say how we were all mind boggled by the efficacy. I think one of the kind of the things that for me has been so transformative is to look at the PFS curves and the tails of those PFS curves that don't drop. So we love to see overall survival, but to see a patient who never recurs, that's transformative. So yeah, and again, you mentioned, in essentially the cohort that wasn't defined by that biomarker, the ones that are in the MMRP category, we do seem to see at least somewhat an effect in that group. We don't really have a great understanding as to why that is, and what that has done is to cause us to dig deeper into not only hypotheses that might explain why an immunotherapy would work in a proficient MMR tumor, but also, are there other potential opportunities based on that molecular annotation? And so now we've started to see this kind of segmentation become even more segmented as we get further down into these, molecular annotated cohorts. So I think that one of the things we should, probably start the conversation with is that when we look at just the pMMR tumor cohort, we do see across different studies varying degrees. Strongest in GY 018, weakest probably in a 10. But we are seeing that these curves do kind of separate for a little bit, and the magnitude of that effect is probably driven by many other factors that we haven't controlled for. And one of those, as we saw from Mansour last year, was to look at what p53 mutation status might inform us of that. And again, of course, we're talking about a subgroup now, p53 wild type versus mutated, of a subgroup, which is pMMR versus dMMR. So I don't want to get too
Yes,
we
are definitely in subgroups and hypothesis generating, but that brings me to, I mean, we saw that difference there in the pMMR, in the pMMR group, but the p53 subsets that had a p53 mutation, and that was by whole exome sequencing, by NGS, not just by immunohistochemistry. But in that non-specific molecular profile is really what we're looking for, other opportunities. And when we first saw, we were really getting to that Selinexor data. Tell us how you decided, because initially that was a negative trial.
Yeah.
How did you start developing this?
Yeah. So, so this is, as people have heard me speak about subgroup analyses and how to interpret them, I actually really applaud the company for trying to actually, kind of put a stake into what is a match between a biomarker, p53 wild type status, and a mechanism of drug, which is to target the XPO1 exportin nuclear exportin protein function, which would allow accumulation of wild type p53 protein in the nucleus to do what we want it to do, which is to govern, these aberrations in cellular mechanisms. So the whole idea here was to take a drug, and again, selinexor is not a new drug. It is for us, but not in the heme malignancy space, where it's also targeting the same kind of mechanism, where it blocks this transfer from nucleus to cytoplasm of what would be considered normal protein. And this is a tumor, to allow this to happen is actually advantageous to the tumor, as it takes out functional protein out of its control, so that the tumor cells can continue to proliferate and with even damaged DNA endlessly. So this is actually was a strategy for therapy. And so what we did is we designed a trial called Siendo that basically looked at the use of this drug as a maintenance strategy in patients who have had, who had responded to index therapy. And so the trial was done. It used a slightly higher dose of selinexor that we would have wanted to use. And actually, if you don't mind, I can actually share that just to kind of highlight what that looks like. I'll just share my screen here real quick, and I can show you what we have. So hopefully that can be seen. So this was the Siendo trial, 3055. And you can see there was 263 patients who had received chemotherapy and had responded to it by the RECIST criteria, then randomization of 2-to-1 of 80 milligrams of selinexor versus placebo. And the endpoint was to look at progression-free survival. And overall, what they saw was that in this intent to treat population, that there was a slight separation in those curves. You can see this slight difference between the blue and the red lines, and you can see what the hazard ratio was. And you can see, unfortunately, that there were some stratification variables that were misallocated, I guess is the best way to say this. And so so the hazard ratio was in an unaudited population was 0.76 with the upper limit over 1.0. However, when it was audited, you can see that when those were correctly allocated by their strata, that it was a 0.71 with a hazard ratio of just under 1. And so this was thought to be potentially a signal, but it was because of this issue. There was actually a call to move this forward and to actually assess it. Well, in this discussion, what we noted was that when we broke out the subgroup for p53 wild type, we saw this kind of efficacy. And so now you can see that the curves are quite a bit split. Now, unfortunately, this is a subgroup, and so the question was, can we reproduce in a formal phase 3 study? And that really led to kind of the Export-EC trial. So I think that's again, it was hypothesis generating, which we're seeing here with a pretty profound effect. And so the hope is that this biomarker, p53 wild type, could actually indeed serve as a surrogate that aligns with the mechanism of action, and hopefully would drive the efficacy we might see in a phase 3 trial.
Yeah, I think this is really great that we're taking it forward and trying to confirm it also with a phase 3 trial. We certainly have seen sometimes that things change when we go from one to the next trial,
Right.
but hopefully this will just see a stronger signal. In this current space, though, like how do you think about this? Like, how do you decide, and when do you decide to get a patient here? Because we now have, we don't have for the pMMR immunotherapy with chemotherapy FDA approved yet, but it is still listed on the NCCN, and it's been pretty wildly adopted. Like, how should people think about it and kind of make their strategy?
It's good question, because I think many of us were influenced by what we saw, and obviously we're waiting for a formal opinion, which should be coming soon. with respect to the efficacy in the PMMR cohort of patients. But as it is right now, we still don't have proof that in that therapy line that this is the most effective strategy. And so I would say that in certainly in patients where p53 wild type is seen, you know, by the same kind of inference that we saw with the p53, excuse me, with the MMRP category, it may be way more nuanced than what we just looking at it from a high level. And so it may be that the PMMR p53 wild type patients should be potentially treated differently than the PMMR, p53 mutated tumors. And so that would be a nuance that would maybe help divide this, because we really don't have in that p53 wild type category, really don't have a strong signal really of any of our adjuvant treatments that we might use, such as bevacizumab or an immune checkpoint inhibitor. So this is kind of where that fits. It fits in that potential population that could benefit, again, with a biomarker, p53 wild type, with a drug that is looking for a p53 normal protein.
And so when you say p53 normal protein, also as in as far as the tumor mechanism, when we think about how we're going to strategize, we're going down the NCCN schema or PROMIS schema, however you want to call it. But some people use NGS, whole exome sequencing. Some people use immunohistochemistry. How should we be testing our tumors at this point?
Yeah.
And thinking ahead, like how we're going to treat our tumors based on those results.
Yeah, I think this is, again, an evolving story. You know, before we had evidence that MSI status was important for primary treatment, we never did check it till patients recurred. You know, right now we're doing kind of more holistic whole genome or whole exome sequencing along with immunohistochemistry for patients with recurrent disease. But I suspect that as time goes on, we will be doing comprehensive testing on all new patients, just so that we have the data available and can make, you know, potential treatment decisions as time goes forward with the development of all of what's being, you know, what's in clinical trial right now. So I think that, but one of the things that is done frequently in most pathology center places that do pathology evaluation of tumors is a p53 assessment. It's kind of like you'll see maybe ER being done as part of an evaluation. p53 may be checked in higher grade histologies to rule out a uterine serous type of tumors, so it can be used as a biomarker to assess that. So frequently we can get that done by IHC. Now, it doesn't necessarily mean that that there's a mutation in p53 by sequencing, but at least the protein is either there or not. And then you'll hear pathologists often say that the p53 staining was done, but it had a wild type pattern. So again, that is, you know, it's an estimate based on what they see, and generally a non you know, amplified or non high level of staining, you know, like a 3+ is, you know, would help them to say that this is wild type pattern or nuclear distribution. But but we found that that's not a great screening tool. So I think for this particular trial, one of the things that we have wanted to message is that we don't often see p53 wild type as a called out biomarker. We just know when it's abnormal. And so what we the relationship between p53 staining by pathology IHC and p53 mutation by next-gen sequencing it's imperfect. I wouldn't say it's, you know, some people are very good at it, but it's imperfect. And of course, loss of protein can be a function of mutation as well as too much protein. So I do think what we're doing, at least with these kind of trials, is we are noting with our biomarker testing p53 wild type status in a patient who qualifies for this trial, the Export-EC trial. You know, we would want to use that as a way to screen, almost as a way of pre-screening that group of patients who then we can send for next-gen sequencing. But I wouldn't leave it exclusively to that because of the disconnect between protein staining patterns and mutation status.
So patients are eligible, though, if they have by immunohistochemistry.
Well, they have to be, that they need to have formal next-gen sequencing testing so that they can go on to the trial. But a way to identify patients while you're thinking about this is you can actually use that IHC screen as a way to kind of like start to put them on your kind of your list of what you want to, who you might want to evaluate.
Mhm. So as we're thinking about this trial as another great option in our exploding armamentarium for endometrial cancer and maintenance strategies also, this is going to be potential third maintenance strategy here in our armamentarium. What should we think about as far as side effects and which patients are particularly should we think about this for this, or should we not enroll?
Oh no. Please
Anybody
enroll.
can?
Please enroll. Yeah. No, I think that so first of all, one of the things that we want to, kind of emphasize in a trial like this is that this particular trial is actually looking for patients that have demonstrated response to chemotherapy. Now, this has been a tough one because many times we might have a patient who had advanced disease and has nothing measurable to follow. But one of the kind of biological biomarkers of an intact p53 mechanism is this response to platinum-based therapy. It would make sense. So we've required this trial that in patients who have either primary stage 4 or recurrent disease, that they have evidence of response to platinum. So that is kind of a first insight into that this is a group of patients for which p53 may be functionally normal. It's almost like what we did with the PARP store, where we used platinum as a surrogate for potential for PARP sensitivity. So kind of a similar type of idea. And so that's kind of the first thing. And then the second thing is that if we find a patient like that, that we talk to these patients early so that they understand what maintenance therapy is. Because those, as you, I'm sure you're well aware too, because you've counseled these patients like me, that, once a patient kind of feels like they just finished their chemo, then they're kind of done and they don't want anything more. So we want to talk to them and talk these patients early on and say, hey, listen, your treatment program potentially could involve a maintenance strategy, and this is why we want to do it. So try to get ahead of that question as well. I think, in counseling patients, we have had some experience. There's been a lot of experience with respect to adverse events that we've seen in our previous treatment exposure from Siendo. But actually, for people who have had experience with Selinexor for non-GYN indications, they're going to be very well versed with what to expect. And the most dominant one that we need to deal with is that of gastrointestinal side effects. And so what we did in between the Siendo trial and Export-EC was to actually mandate that there be dual antiemetic prophylaxis for the first 2 cycles. So a lot of this is expectation, just like we do with regular chemotherapy, but talk about that this GI side effect could happen. And then we, for the first 2 cycles, have used a mitigation strategy that would involve an F5HT3 and an NK1 type drug to be used for the first 2 cycles, and then go back to kind of a standard approach. And we think that will help mitigate some of that adverse events.
Yeah, that's great. And really, if we think about how we got to the PARP inhibitors too, yes, that's how we started, and we're a little worried about the nausea, and we see that improving too with time. And it sounds like we may, with good maintenance, good strategy and preventative things, we'll be able to manage this. This is great. It's wonderful to hear all these options developing and really narrowing it down and very much getting to this personalized treatment of endometrial cancer, and hopefully going against our rising death rates that we've seen in endometrial cancer, and really starting to make some improvement for all these specific populations, and hopefully to a magnitude as we're seeing in a mismatch repair deficient population with immunotherapy as well.
Yeah, one thing I might want to mention too, just because I know people get nervous about adverse events, particularly in a maintenance setting against placebo. In this trial, we went back and actually looked at the Siendo trial for the dosing that was found there. We found that although it started at 80 milligrams, most patients basically ended up at 60, which is where this trial, Export-EC, is actually starting. So we're fairly confident that we're with the mitigation strategy and the dosing adjustment that we should be able to get through treatment as we hope.
Excellent. Well, I think this is another great, exciting option, and I really hope that we'll be able to complete, or you'll be able to complete this trial and get the results. Hopefully, as exciting and confirmatory to what we saw initially, but at least get the right answers and find it out in the right ways. So, congratulations on leading this. And thank you so much for taking the time to talk to this today about mismatch repair proficient endometrial cancer and some new developments in this maintenance space.
We thank you, and I really appreciate taking the time out to walk through it and help understand what the value this kind of trial might bring to our patients. Really appreciate the invitation.
Excellent. With that, we'll conclude our webinar or podcast, however you're listening to this, and we look forward to having you join for our next series.